Here is what most people over 60 get wrong about blood pressure. They are still chasing 120 over 80, a target that was studied mostly in people decades younger than them, while the actual research on adults over 60 tells a more complicated and honestly more useful story. In 2017, the American College of Cardiology and the American Heart Association changed the definition of high blood pressure, and by the ACC and AHA's own estimate, roughly 30 million Americans woke up hypertensive who had gone to bed with normal numbers. Even though an older guideline from 2014 had told doctors that people over 60 could relax all the way up to 150. So depending on which doctor you saw and in which year, the same reading of 142 was either perfectly acceptable or a reason to start medication that week. If you have ever felt confused about what your numbers are supposed to be at your age, that confusion is not your fault. It is baked into the research itself, and today I want to walk you through it carefully. Because there is one more wrinkle that almost nobody explains. After 60, one of your two blood pressure numbers starts behaving strangely. It drifts in a direction that surprises people, and the number that matters most for your risk of stroke and heart attack is probably not getting the attention it deserves on your home monitor. I will show you exactly which number that is, why it changes, and what the strongest studies we have actually found when they tested different targets in people your age. And near the end, I will show you a 30-second check you can do at home with the monitor you already own that catches a treatment problem most people never discover until it puts them on the floor. Here is exactly what this video covers, in order. First, the actual target ranges that the major guidelines and the landmark trials support for adults over 60, including the specific places where the American and European recommendations disagree and why. Second, the reason systolic pressure, the top number, becomes the number that matters most after 60, explained with a water tower analogy you will remember at your next appointment. Third, the home measurement routine, backed by American Heart Association guidance, that removes the 10 to 15 points of false elevation that common mistakes add to your readings. Fourth, the three situations where pushing blood pressure lower may cause more harm than good in older adults, which the big trials documented but the headlines skipped. And fifth, the standing check that takes 30 seconds, uses your existing cuff, and flags a fall risk that guidelines specifically warn about in people over 65. Quick word on where this is coming from. I am a physician, and this channel focuses on cardiovascular health for older adults. Everything in this video comes from published trials and guidelines that I will name as we go. And to be clear from the start, this is education, not medical advice. Your target, your medications, and any changes to them get decided between you and your own doctor, who knows your history. My job today is to make sure you walk into that conversation understanding the research as well as anyone in the room. Let me tell you about Carol. Carol is a composite of patients I have seen many times, but her situation is exactly typical. She is 68 years old, lives outside Dayton, Ohio, retired from 31 years as a school administrator, and she has been watching her blood pressure since her early 60s. In 2016, her doctor at the time looked at a reading of 144 over 82 and told her not to worry. At her age, he said, anything under 150 was acceptable. He was not being careless. He was following a published guideline, and I will show you which one in a minute. Carol went home reassured and mostly stopped thinking about it. 7 years later, that doctor retired, and in 2023, Carol sat down with a new physician. Same Carol, similar reading, 141 over 80. The new doctor looked at the number and said something completely different. This is stage 2 hypertension. I would like to talk about starting medication. Carol was stunned. She asked the obvious question, the one you may have asked yourself. Which is it? Was the first doctor wrong, or is the second doctor overreacting? She went home and searched online, and it got worse. One site said 120 over 80. Another said 130. A third said older adults could go to 150. A fourth said targets should be personalized, which told her nothing. Carol did what a lot of people do when the information contradicts itself. She quietly stopped trusting all of it. She put the home monitor in a drawer. She skipped a follow-up appointment. And for about 8 months, she measured nothing at all. Then one afternoon at a pharmacy, she sat down at one of those public machines, mostly out of curiosity, and it read 162 over 94. That number scared her enough to get back into a doctor's office, and this time she asked for the full explanation. The reason I am starting with Carol is not that her story is unusual. It is that her story is the predictable result of a real disagreement inside the research, a disagreement that played out between 2014 and 2017. And if you are over 60 in America today, both sides of that disagreement have probably shaped what different doctors have told you. According to CDC data, nearly 3 out of 4 adults over 65 have high blood pressure by the current definition. So this is not a niche question. This is the single most common chronic condition in your age group, and the confusion Carol felt is shared by tens of millions of people. So here is what actually happened, in plain language. In 2014, a panel of experts, often called the JNC8 panel, published recommendations saying that for adults 60 and older, doctors could relax the treatment goal to under 150 over 90. Their reasoning was cautious. The trials available at the time had not clearly proven that pushing older adults lower produced better outcomes, and lower targets mean more medication, and more medication in older adults means more side effects. That is the guideline Carol's first doctor was following, and in 2016 it was a defensible position. Then came SPRINT. SPRINT was a large trial funded by the National Institutes of Health, published in the New England Journal of Medicine in 2015, with more than 9,300 participants, all of them at elevated cardiovascular risk, and importantly, more than a quarter of them aged 75 or older. SPRINT asked a simple question. If we treat systolic blood pressure down toward 120 instead of the traditional 140, do people actually do better? The trial was designed to run about 5 years. It was stopped early, at a little over 3 years, because the answer was already clear. The intensive group had roughly a 25% lower rate of major cardiovascular events, heart attack, stroke, heart failure, and about a 27% lower rate of death from any cause. And in the pre-specified subgroup of participants aged 75 and older, the benefit held up for cardiovascular events, though the effect was strongest for those events, and the signal on death from any cause was weaker in that oldest group. That result reshaped the field, and it is a large part of why the 2017 American guidelines redefined high blood pressure as anything at or above 130 over 80, and set a general treatment goal of under 130 for most adults, including many older adults who can tolerate it. That is the guideline Carol's second doctor was following. So both of her doctors were reading legitimate guidance. They were just reading it from different years. Now here is the detail that almost none of the news coverage explained, and it matters enormously for you at home. SPRINT measured blood pressure under nearly ideal conditions. Participants sat quietly for 5 minutes, often alone in a room, and an automated machine took multiple readings with nobody talking to them. Readings taken that way typically run 5 to 10 points lower than the numbers taken in a busy clinic hallway or at your kitchen table while the television is on. Which means SPRINT's target of 120, measured their way, corresponds to something closer to the upper 120s or 130, measured the way most of us actually get measured. When people miss that detail, they either panic over readings that are actually fine, or chase a number lower than the trial ever intended. Now let me explain why the top number is the one that deserves your attention after 60, and for this, think about a water tower. A town's water system holds pressure in the pipes, and the pipes matter as much as the pump. When the pipes are young and flexible, every surge from the pump gets absorbed and smoothed out, so the pressure downstream stays steady. Your arteries in your 30s worked exactly like that. Elastic walls caught each heartbeat's surge and released it gently between beats. But over decades, arterial walls naturally stiffen. The elastic fibers wear, and the walls behave less like flexible tubing and more like rigid pipe. And in rigid pipe, the pump's surge is not absorbed, it slams straight through. That surge is your systolic number, the top one, and this is why systolic pressure tends to climb steadily with age, while the bottom number, diastolic, often flattens out or even drifts downward. So here is the one line to carry into your next appointment. Same pump, older pipes. The surge that soft young pipes used to cushion now slams through at full force, and that full force surge is your top number. Doctors call that pattern isolated systolic hypertension, and it is the most common form of high blood pressure after 60. It is also why the research consistently finds that in older adults, systolic pressure predicts stroke and heart attack risk better than diastolic does. So that strange behavior I mentioned at the start, this is it. Your top number rising while your bottom number falls is not your monitor malfunctioning. It is stiffening pipes, and it is precisely the pattern the big trials were built to treat. When Carol finally heard this explanation, the whole 7-year contradiction collapsed into something simple. The pipes had changed, the science had changed, and nobody had walked her through either one. I want to give you 3 more people because Carol is only one version of this story, and your situation may look more like one of these. Robert is 74, lives in Tucson, a retired electrician, and his story is the mirror image of Carol's. After the 2017 guidelines came out, his doctor treated his blood pressure aggressively, and Robert was diligent about it. 3 medications, taken faithfully, and his home reading settled around 116/64. On paper, a triumph. But Robert started noticing that when he stood up from his recliner, the room grayed out for a second or two. He mentioned it to nobody, because he assumed it was just age. Then one morning he stood up quickly from the kitchen table, lost his balance, and went down hard against the counter, bruising 2 ribs. Here is the part worth knowing. Sprint itself documented this trade-off. The intensively treated group had higher rates of hypotension, fainting, and certain kidney measures moving in the wrong direction. The benefit was real, but so was the cost, and in an older adult, a fall is not a minor cost. Robert's doctor spaced out his medications, adjusted one dose, and his reading settled near 128. The graying out stopped. The lesson is not that treatment is bad. It is that lower is not automatically better for every individual, and how you feel standing up is data your doctor genuinely needs. Eleanor is 81, lives with her daughter's family in Grand Rapids, and her family had quietly concluded that blood pressure treatment was pointless at her age. Why burden her, they figured. But there is a trial that speaks directly to Eleanor, called HYVET, published in the New England Journal of Medicine in 2008, which enrolled only people aged 80 and above. It found that even a gentle target, getting systolic down to around 150, cut strokes substantially, cut heart failure dramatically, and reduced death from any cause by roughly a fifth. Treatment in the 80s is not futile. The target may be more modest, and the approach more careful, but the benefit is documented in people Eleanor's exact age. She started one low-dose medication with her doctor and tolerated it without trouble. And then there is James, who is 63, still working, in Charlotte, and whose problem turned out not to be his arteries at all. Every reading in his doctor's office came in around 148. Every reading at home, taken properly, averaged 126. That gap has a name, white coat hypertension, and studies suggest it affects somewhere between 15 and 30% of people with elevated office readings. James was nearly started on daily medication for a number his body only produced in a clinic. A week of structured home readings, brought to his doctor, changed the entire plan to monitoring instead. 3 different people, 3 different failure points. Carol was lost between 2 eras of guidance. Robert was treated past his own tolerance. Eleanor was written off by assumption, and James was almost treated for a measurement artifact. The common thread in all 4 stories is that the number on the cuff, taken correctly and interpreted for your age, is what separates the right decision from the wrong one. So here is what to actually do with all of this, in order. First, establish your real average with a proper home measurement week, because everything else depends on this number being true. Use a validated upper arm cuff, not a wrist monitor, since wrist devices are far more sensitive to position error. Sit in a chair with your back supported and both feet flat on the floor, legs uncrossed. Rest quietly for 5 full minutes first. No phone, no television, no conversation. Support your arm on a table so the cuff sits at the level of your heart. Empty your bladder beforehand and skip caffeine for at least 30 minutes prior. Then take 2 readings 1 minute apart, in the morning before any medications, and again in the evening, for 7 days. Discard the first day, which tends to run high from novelty, and average everything else. That averaging protocol follows American Heart Association guidance, and here is why the fussy details matter. Per the AHA, a full bladder can raise a reading 10 to 15 points. Talking during the measurement, about 10 points. An unsupported arm hanging below heart level, up to 10 points. Crossed legs, 2 to 8 points. A cuff wrapped over a sweater sleeve, 5 to 50 points depending on the fabric. That is the measurement mistake I promised to explain, and it is really 5 mistakes stacked together. Some people carry a diagnosis built partly out of technique errors, and some people are walking around falsely reassured for the same reason. Second, know the reference points the research actually supports, so the numbers on your screen mean something. Under the current American guidelines, normal is under 120/80. Elevated runs from 120 to 129 systolic. Stage 1 begins at 130/80, and Stage 2 at 140/90. European guidelines have generally been a bit more permissive for adults over 65, often suggesting a systolic landing zone in the low 130s when treated. And a Chinese trial called STEP, published in the New England Journal of Medicine in 2021, tested adults 60 to 80 and found that targeting systolic between 110 and 130 reduced cardiovascular events by about 26%, compared with a looser target. So if you want a research-grounded summary, it is this. For many adults over 60 who tolerate treatment well, the evidence supports aiming somewhere near or below 130 systolic, as measured at home, while for adults in their 80s or those who feel unwell at lower pressures, a more modest target may serve better. Your specific number belongs to a conversation with your doctor, not a video. And know the emergency line, which is not controversial anywhere. A reading at or above 180 systolic or 120 diastolic, especially with chest pain, shortness of breath, vision changes, weakness on one side, or severe headache, is a reason to seek emergency care immediately, not to remeasure tomorrow. Third, bring 3 specific questions to your next appointment, written down. Question 1. What is my personal target and which guideline or trial is it based on? A good doctor will happily answer, and now you will understand the answer. Question 2. Has my diagnosis been confirmed outside the office, with home readings or 24-hour monitoring? Remember James. Question 3. Do any of my other conditions or medications change what my target should be? Because kidney disease, diabetes, and a history of falls all legitimately shift the math. Fourth, work the lifestyle levers with the strongest evidence, because they are not decoration, they move real points. The DASH eating pattern, developed in NIH-funded research, lowered systolic pressure by roughly 8 to 14 points in trials, more when combined with sodium reduction toward 1,500 to 2,300 milligrams a day. A 2023 meta-analysis in the British Journal of Sports Medicine found that isometric exercise, things as simple as wall sits and hand grip holds done a few times a week, lowered systolic pressure by around 8 points on average, performing as well as or better than traditional cardio in that analysis. Add consistent sleep and moderated alcohol, and for many people these habits stack into a double-digit reduction. They may not replace medication, and no one should promise you they will, but they can make every other part of the plan work better. And fifth, learn the signs that treatment may be overshooting, because Robert's story is common and mostly silent. Lightheadedness when you stand, unusual fatigue, readings consistently below 110 with symptoms, or any graying of vision on rising. If you notice these, do not stop or skip your medication on your own, because rebound can be dangerous. Call your doctor, describe exactly what you measured and felt, and let them adjust the plan. That phone call is the entire action, and it is one of the most protective calls an older adult on blood pressure medication can make. Now the check I promised at the beginning, the one almost nobody does at home even though it uses equipment you already own and takes about 30 seconds of actual measuring. It is called an orthostatic check. Here is how it works. Take your blood pressure seated after your normal 5-minute rest. Then stand up and take it again after 1 minute of standing, and once more at 3 minutes. What you are looking for, per standard clinical criteria, is a drop of 20 points or more in systolic, or 10 points or more in diastolic after standing. That pattern is called orthostatic hypotension, and it matters because it is a documented, independent risk factor for falls in older adults, and falls are among the leading causes of injury death in people over 65, according to the CDC. It is also exactly the pattern that shows up when blood pressure treatment is running hotter than an individual body can handle, which is why the current guidelines specifically suggest checking for it in older adults being treated for hypertension. Robert's problem would have shown up on this check months before his ribs found the countertop. 2 cautions. If you already know you get very dizzy on standing, do this with someone nearby and a chair behind you, and stop and sit if you feel faint. And this check is a screening tool, not a diagnosis. If you find a drop that meets those thresholds, write down the numbers and bring them to your doctor. Do not adjust anything yourself. If your standing readings look the same as your seated ones, that is genuinely reassuring information, and now you have it. Either way, doing this once or twice a year costs you nothing, and can surface a problem while it is still just a number on a screen, instead of an event on the kitchen floor. If you take one thing from this video, take this. The question was what the ideal blood pressure is after 60, and the honest answer from the research is that for many adults over 60, a home average near or below 130 systolic, achieved without dizziness or falls, is the zone the strongest trials point toward, with more modest goals often making sense in the 80s. But that answer only means something if the number feeding it is real, and the number only becomes real when you measure correctly. 7 days, proper technique, averaged. Carol did exactly that. She came back to her doctor with a page of honest readings. Her home average turned out to be 137, and together they made a plan she actually understood and stuck with. That is the whole goal here. Not a magic number, but a true number, interpreted for your age, in partnership with a doctor who knows you. One more time, because it matters. Nothing in this video replaces that partnership. It is meant to make you the best informed person in the waiting room. If you know someone over 60 who is confused about their numbers, a parent, a spouse, a neighbor who keeps their monitor in a drawer like Carol did, send them this video, because the 7-day measurement week is something they can start tomorrow morning. And if this helped you understand your own numbers better, A like tells me to make more like it. And subscribing means you will see the next one, where we go through the most common blood pressure medications, one by one, and what the research says about their side effects in older adults. Take care of yourself. And I will see you in the next one.